Chapter 38, The Child with GI and Endocrine Disorders. This will be a two-part series, so we'll start with GI. The GI system is responsible for taking in and processing nutrients. It nourishes all the parts of the body. GI tract begins to develop during the third week of gestation. A lot of times GI disorders may be caused from congenital disease, acquired disease, infection, or injury. Digestive enzymes aren't present in sufficient amounts whenever they're first born, a child is first born, and that's why they are solely on formula or breast milk until about 4 to 6 months of age, and then they can slowly start taking in other nutrients, starting with rice cereal and then progressing to new foods. We know that every time we introduce a new food, we need to wait about 4 days and introduce one food at a time to rule out any kind of allergies. GI functions include digestion, absorption of nutrients, water, secretions of various substances, and elimination of waste products. The stomach of a newborn is small. Peristalsis is greater in newborns than in older children, and this is the reason for small, frequent feedings and increased frequency. Often you'll have liquid consistency of stool as well. Structural defects may occur when growth and development of fetal structures are interrupted during that first trimester. We've talked about cleft lip, cleft palate. They're two very distinct facial defects. Cleft lip is congenital anomaly involving one or more of the clefts in the upper lip. You can have it one-sided, two-sided, bilateral. It can be small or it can go all the way up into the nasal cavity. The degree of the cleft varies. Cleft palate is a congenital anomaly as well, consisting of the cleft ranging from the soft palate involvement to the defect including the hard palate. And that's, the palate is talking about if you raise the top of your tongue to your roof, you'll feel your palate. So it can go all the way up and it can cause severe abnormalities. It can be a simple surgery or it can be many surgeries throughout that child's life. Causes include hereditary, environmental, and tetragenic factors. With cleft lip, the defects are apparent at birth. Repairs of lip may be done as early as 2 months of age. The lip is usually sutured using a diagonal incision or a Z-plasty. That allows a little bit more movement and won't tear quite as easily. The child would be placed, of course, in elbow restraints, making sure that they don't flex or try and touch that surgical line. Children should receive distraction and pain medication to prevent any kind of crying. Of course, crying would strain that suture line as well. Early closure of cleft lip allows the infant to form a better seal around the nipple for feeding, and therefore they try and get it done as early as they can. Sucking motion strengthens the muscles necessary for speech. Cleft palate, timing of the repair is controversial and may depend on the size and the severity of the actual cleft. Usually performed around 18 months of age, and that's before a child starts talking. Postoperative care, you're going to do frequent vital signs, maintain airway, strict eyes and nose, assessing oral cavity every 2 hours as needed for tenderness, redness, lesions, and secretions. You're going to be cleansing the cleft area by giving 5 to 15 mils of water after each feeding, making sure that none of that milk stays up there, creates any kind of stasis. And of course, use careful hand washing and sterile technique when working with the suture line. Postoperative care, airway management includes assessing respiratory status, vital signs, cardiorespiratory monitor, having suction available, connected, gently suctioning as needed, providing cool mist for 24 hours, and repositioning every 2 hours. Elbows will be kept in softer strains, removing those every 2 hours, assessing the skin, and of course reapplying those restraints. You'll never leave a child unattended while the restraints are removed. Of course, you know a child, their hands will go straight for that suture line and could mess up that suture line as well. After cleft palate surgery, avoid the use of any kind of metal utensils, pacifiers, straws, anything that could damage that surgical site. You won't really be allowed to put anything into that child's mouth. Providing pain control, of course, and allowing parents to hold and comfort the child. Emotional needs are going to be evaluated in this as well. With esophageal atresia and tracheal esophageal fistula, basically you have your esophagus, you also have your windpipe, and when you have esophageal atresia, there is a malformation that results from failure of that esophagus to continue down as a tube into the stomach. Typically it's formed during the 4th or 5th week of gestation, and something just goes wrong during that time. The esophagus may end in a blind pouch, which you can see in figure A and B. It's just right there. Obviously it's not going into the actual windpipe. However, the esophagus could develop as a pouch and be connected by a fistula to the trachea, which you can see in these examples here. Oftentimes it is associated with maternal history of polyhydramnios. Of course, we know that is excess amniotic fluid. Symptoms: excessive salivation and drooling. They're not really able to swallow it, so they're just going to have pooling of drool coming out of their mouth. Of course, it can be accompanied by cyanosis, choking, coughing, sneezing, and during feeding, the infant returns fluid through the nose or the mouth, so you'll actually see the milk coming back up through the nose or the mouth. Aspiration places the infant at risk for pneumonia. We typically are able to diagnose this by attempting to pass a 5 or 8 French nasogastric tube into the stomach. The tube will meet resistance and can only be advanced minimally. When we do an x-ray, we're able to see that there is a pouch. Echocardiogram, abdomen ultrasound, lungs are all examined very carefully. The tube will be inserted into that upper pouch and to be allowed to suction out all those secretions. Suction may be continuous or intermittent. The child will then be, of course, NPO, and we will be giving IV antibiotics. Surgery as soon as possible to fix that problem. A G-tube may be needed temporarily or permanent if the surgery is not possible, or they're not able to make the esophagus go down into a full line. You can see right here, that's the skin, that's the stomach, the G-tube goes right there. You would put your feedings in, and then of course it could continue on to the small intestine. Amorphocele, these are congenital malformations in which the intra-abdomen contents herniate through the umbilicus cord. So protrusion is actually covered by a translucent sac, and you can kind of see that here. It is all encased into a small sac. It's usually associated with other congenital anomalies such as cardiac anomalies, genitourinary anomalies, and trisomy traits like Down syndrome. Gastroschisis occurs when the bowel herniates through a defect in the abdomen wall. As you can see here, there is no membrane covering that bowel. There is no actual sac covering it. And it's usually not associated with any congenital anomalies. You can see right here, this is a gastroschisis silo. They put the contents into this sac, and then they will slowly allow gravity to put the intestines back into the child's abdomen. It's kind of a slow process. They'll go in, they'll tighten the sac a little bit more, but trying to go in and do it for surgery or make it too quick, the child will have some abnormalities on its stomach. So they have found that just allowing gravity to do it actually works better. You can obviously see that the defects are visible at birth. You want to maintain a sterile technique when dealing with the defect, and any exposed contents need to be covered with a sterile gauze soaked in warm saline solution, and then covered with sterile plastic to keep that moisture and heat inside. Celiac disease. It is a chronic malabsorption syndrome in which the person has an intolerance for gluten products. Gluten is actually a protein that is found in wheat, barley, rye, and oats. So this person can have corn and corn products, but they cannot absorb wheat, barley, rye, or oats. Celiac disease is an immunological disorder that causes an inability to digest gluten protein fractions, which results in the accumulation of the amino acid glutamine. The accumulation is toxic to the mucosal cells in the intestine, which in fact causes damage to the villi, which is the hair-like structures on the intestine. It impairs the absorption process in that small intestine. They're not able to, those villi, the hair-like structure isn't able to hold on to those nutrients. It just kind of comes in and it's almost like it cuts it off completely. Early stages affects fat absorption, large quantities of fat in the stools, dysuria. But here you can see where those small villi, it just cuts it off. They're not able to absorb anything. So as the intestinal villi continue to change, absorption of protein, carbohydrates, calcium, iron, folate, vitamins A, D, E, K, and B12 all become very impaired. And so this child can be very sick and will often look like they're just kind of wasting away. You can see a picture of it on page 842, where they just don't have much of a butt and their stomach is protruding out. A lot of times they'll have chronic diarrhea, vomiting, irritability, and just failure to grow. They may demonstrate evidence of protein deficiency, wasted muscles, abdomen distension, can also have delayed dentation and changes in bone density, and of course delayed growth and development as well. Diagnosis by measurement of fecal fat content, jejunal biopsy, or as simple as removing the protein and seeing improvement in the child. Symptoms will improve within the first days, 2 weeks, and the intestinal villi will return to normal within 6 months. Growth should start steadily improving. Vitamin supplements may be needed. And then, of course, teaching, we have to remind the parents that this is a lifelong dietary modifications. There is no going back or adding wheat whenever they start feeling better. It's for life. They need to know that they cannot discontinue it when the child is symptom free, and that failure to remain on the diet places that child at risk for growth retardation and even GI cancers later on in adulthood. So compliance may be more difficult when the child attends school and is more involved with peer groups. There is a large variety now of gluten-free products. Of course, most people don't necessarily cook with it unless they do struggle with celiacs, but even still, there are lots of options now, more so than before. Gerd is gastroesophageal reflux. It's the return of the gastric contents into the esophagus. It's the result of relaxation of that lower esophageal sphincter right at the top of the stomach. Typically self-limiting, but severe cases may require surgery where they actually take a little piece of the stomach and kind of wrap it around the esophagus to make that a little bit tighter so the fluid isn't returning back up there. One of the most common gastrointestinal disorders of children, there is a higher incident in premature infants. This is one exception where the doctors actually recommend the babies laying prone or on their stomach because it will help them not to spit up as much. It's often manifested, GERD is manifested by poor weight gain, esophagitis, excessive spitting up, forceful vomiting, irritability, recurrent respiratory infections, blood and stool, apnea, or even near sudden death syndrome. And you can see here where that sphincter is just not closing all the way and the liquid goes up.